By listening to this podcast, you agree to not use this podcast as medical advice to treat any medical condition in yourself or others, including, but not limited to, patients that you are treating. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast. Under no circumstances shall any guests or contributors to the podcast or any employees, associates, or affiliates of the Neuroendocrine Cancer Awareness Network be responsible for damages arising from use of this podcast. Hello, everybody. Happy New Year, and welcome once again to Nets Get Real with NCAN. I'm your host, Mike Wayman from NCAN, and we're back. We're in the swing. It was kind of a crazy end to the 2022. We had a really successful conference in Atlanta, Georgia, and now coming up this year, we've got 5 in the works, smaller regional ones, but please make sure you go to netcancerawareness.org and find a local meeting near you, or find something that interests you to go travel somewhere. You know, we've got something in the DC area, Nebraska. We've got San Diego, Miami, Cleveland, Ohio. So we're hitting all the spots we got to hit. Today we have the hematologist and oncologist from Mayo Clinic in Jacksonville, Florida. We've got Dr. Jason Starr. How are you,
Hi
sir?
there. Good. Nice to be here. Thank you.
No, thank you for coming on. You are a host in your own right when it comes to podcasts. Back when we were at NCAN, you had the fancy background and everything, hosting your own podcast there too.
Yeah, that was my debut for the podcast, and I was thinking of going up against Joe Rogan and see if I can outdo his following. But no, it was a lot of fun, and doing it live at NCAN added another element. But we had a lot of fun with it. It was a good time.
Yeah, it was a really it was really cool to watch. I don't know if you got to see the fun jousting match, oncologist versus surgeon with Dr. Reddy and
yes,
and
was it Dr. Howe?
Dr. Howe, yeah.
Yeah.
Those are always my favorite at the conferences. You get them up there on a Q&A panel. You get an oncologist and a surgeon, and the sparks fly. It's always fun.
Yep. Yeah. So there's always, obviously surgeons are going to, usually kind of preference surgery, and the med oncs are, going to kind of try to talk them down every once in a while. But yeah, everyone has the patient's interest in mind. So that's all that matters.
Absolutely. Now, so this is not the first time that we've virtually met, despite the fact that I thought that you've been doing NCAN things for years now. I've been recording the conferences for God, it's got to be like 15 years now. And I was like, oh yeah, Jason Starr. But it turns out that you only did a couple of the virtual ones.
That's right.
And you had obviously stood out to me because I edit all of them and end up going, okay, well, we should bring this speaker in, and it wasn't until the pandemic that we got to meet you. So yeah. I'm really glad that you got to come to Atlanta and do your thing, because you're a great speaper, and that's why we have you here.
I appreciate it. Yeah, the NCAN conference, being at my first one, phenomenal. What an event. I loved the interface, that patients were able to have that forum to feel, freely come up and talk to, anyone. And there was no barriers. There was no, he's a white coat and a patient. It was just, hey, we're here for one reason. Let's talk, And so I connected with a lot of patients and colleagues. I had a blast.
Great. Yeah, it was a lot of fun. It was a whirlwind of a week for me. So it was a lot of good,
I could only imagine. I can
Yeah. Oh
only
yeah. Yeah.
imagine putting
It
that
was good.
together. And then you had the gala, I think maybe a couple
It was
weeks
the week
after,
after.
the
Nope.
week
It was
after.
the very week after. It was the very
Yeah.
week after.
So
So it was like I said, a whirlwind of the last couple months, but here we are, 2023, and now we only have
yeah,
five. We only have 5 conferences this year,
only. Yeah.
and yeah, and 2 galas and
Right.
walks and all the it
It's
never ends.
wonderful.
But it's a good thing.
Yeah,
It's a good thing.
it is. It is.
So what I would really like to know is a little bit about yourself and tell us what led you to become a net specialist.
Yeah. So, I'd love to tell a story as, kind of this, kind of epiphany or, this story of, some personal experience that would kind of push me into the direction of taking care of folks with neuroendocrine cancers. But actually, it was a bit serendipitous. I was at University of Florida at the time, and I was in my fledgling stages. I was a junior attending, and my mentor there, Dr. Tom George, who is as fantastic as it gets, just a dynamic, incredible individual who has a never-ending amount of energy to contribute to fighting cancer. Um, Said, "Hey, you've been seeing neuroendocrine cancer lately and taking care of those patients. Is that something that you're interested in?" And I was like, I had to think about it. I was like, yeah, I have been, and I do enjoy it. And then ever since then, it kind of set a fire or kind of the spark to say, hey, this is something I want to do for a lot of different reasons. One is I felt like it was an underserved medical community, right?
Mhm.
Where it's very nuanced. And if the oncologist or the medical team didn't understand the nuances, the patient might not get the best treatment. And so I felt like, well, I want to master those nuances and be able to confidently provide the patients with the best care. And so it was a challenge in that regard. I also enjoy that there's a lot of internal medicine. I consider myself an internist at heart, in terms of my medical background and going through medical training. I'm an internist, and so there's a lot of times where you have to kind of really work through some internal medicine problems, if you will, to get to a diagnosis. For example, carcinoid syndrome is like a classic internal medicine teaching, right? Um, and so for that reason, I enjoyed it. And the other thing I really loved was the relationships and the continuity, right? I'm thankful that I get to take care of my patients for years, you know,
Yes.
and I love that I can tell patients that, hey, the prognosis with this disease is generally good and it's getting better. And so, being able to follow patients for those years and see them, reach milestones and go to weddings and graduations is so rewarding. It's the reason that we all decided to do what we're doing, right? To enrich,
Sure.
to make someone else's life better, right?
Yeah.
And to offer something to a fellow human. So for all those reasons, I fell into essentially the field of neuroendocrine cancers, and I'm thrilled, and that I was able to do that.
That's great. That's great. Now, on the patient side of things, why do you think it's so important for patients to be involved in their treatment plan?
Hmm. Yeah. So I, I will say, and I think from your observations, you would agree. Patients with this disease tend to be very well informed, have a
Yeah.
very high healthcare literacy. And that doesn't just come naturally, right? That's because patients are seeking answers, right? Um, and it's important because of what I had mentioned in terms of the disease being nuanced, right? And if their treating physician doesn't understand these nuances, I always encourage patients to advocate for themselves. to ask the questions, right? And if they're not getting the answers, or the oncologist admits that, hey, this isn't something I deal with regularly, and my comfort level for, answering these questions is not high, maybe you should see a specialist, right? So I like for patients to come, fully prepared to know, hey, what questions do I need to ask, and why am I asking them, and how does that dictate my care? So, I try to teach my patients to be advocates for themselves, and essentially a lot of my patients end up having more knowledge than the general medical community,
Yeah.
physician trained or otherwise. And so I'm always proud of that. But it's really important to understand nuances, because that could be the difference between the correct treatment and not the correct treatment.
Absolutely. Absolutely. Now, in regards to getting that proper care, what do you think is the most important decision a NET patient can make?
Yeah. So, I mean, doing your homework is important, right? So you want to have confidence that that provider, has good experience, and, because a lot of things in medicine, right, you can read, and we read papers, but a lot of things in medicine are experiential, right? And there's certainly an art of medicine that goes with the evidence-based, papers and the scientific things.
Mhm.
So you want to find a medical team and an oncologist who you can be confident understands that art, and that each patient is individual in their presentation with a neuroendocrine cancer. So there are some resources. NCAN provides, carcinoid.org, Net Research Foundation, where they will list an expert in your area, and then you can seek out that expert so that and they can work in conjunction with your local oncologist. If they're far away, do a video consult, right? Make
Yeah.
sure you're on the right track, and that oncologist would be happy to. I know I would, to make sure that that oncologist gets the correct information. Um, and trust me, you're not stepping on toes, right? There's there should be no ego involved on behalf of the physician. If the physician gets offended that you sought a second opinion, you should find another physician. That's my rule of thumb.
Yeah.
Because if that means that your best interest is not at heart, their ego is above that. So you want to steer clear of that. So I think seeking out searches online to find a neuroendocrine expert in your area.
I love the fact that you brought that up, because excuse me, I don't think there are enough doctors that say that publicly. So I do think that is super important, and yeah, again, definitely find a specialist and work in conjunction with. If the specialist is far away, you should have a doctor local, obviously, but they have to be willing to collaborate, because as far as carcinoid or NET cancer is concerned, you gotta have a team. You gotta have a full team with
Absolutely. And that's another point, when patients are making a decision, you need a multidisciplinary team, right? So you need a good gastroenterologist, you need a good radiation oncologist, or a nuclear medicine doctor if you're considering PRRT. You need a good surgical oncologist, right? It's all those components. It's not just
Yeah.
me, right? It's the whole team and the team approach. That's what you're looking for. So at Mayo, for example, we have, a multidisciplinary neuroendocrine tumor board that meets, and we go over, essentially, I don't want to kind of sound callous, but we go over cases, which
Mhm.
are patients, and that are more challenging and need a combined input, right? And need a lot of different, vantage points and points
Sure.
of view.
I love that. I love that. So what are you going to present to us today? I'm actually looking forward to this.
Yeah, so originally I would say, oh well, just kind of off the cuff, and we could talk about general all things neuroendocrine. But actually, I have a presentation that I did for our neuroendocrine support group here in Jacksonville, called the Northeast Neuroendocrine Zebras. And actually, Mayo, we help to run that tumor board, and all are welcome. Sorry, support group, not tumor board. All are welcome to that support group. And there's actually a link to it on mayoconnect.mayo.org. And so there's a neuroendocrine tumors. You type it in the search bar, and it'll bring you to essentially a message board, which is a kind of a virtual support group. You can post a message and get it, have somebody respond or another patient respond. But we also list the link to that support group embedded in the discussions.
Excellent.
So I gave this presentation to them. It's a general overview of neuroendocrine cancer, things you want to ask your doctor, misconceptions, truths, and myths. So we're going to go over that, and hopefully folks find it helpful.
Awesome. Well, Dr. Starr, the floor is yours. I'm going to pop out of here.
All right. Sounds good. All right. So let me pull this up here. And then maybe if you could just confirm that it's projecting. Yes, it is. Perfect. All right. So neuroendocrine cancers, myths, terms, and facts. So neuroendocrine tumors, first described in the mid-1800s, given the name carcinoid by a pathologist named Dr. Oberndorfer. And actually, carcinoid or carcinoid in German means cancer-like. So they looked under the microscope, and the tumors looked kind of bland, if you will. They didn't look aggressive. And for that reason, it was a misnomer, right? Carcinoid's a misnomer to say cancer-like, because we know that this is cancer, and we know that it can spread. So there was a misconception about neuroendocrine cancer, or NETs, originally. And for reasons not clear, the cells can proliferate and lead to tumors. In some situations, there are more clear reasons, but the majority, there's not. For example, the most common place we would find a neuroendocrine tumor in the small bowel. We don't understand exactly why do these tumors arise in the terminal ileum. We know that there's a rich amount of neuroendocrine cells in that area, but what triggers the cancer, right? And we don't understand that at this point. And I hope we're working closer to that. We have a lot of scientists and brilliant folks in the lab that are doing this, that are unbelievably talented. NCAN, Net Research Foundation, all of these organizations give scholarships and grants to folks to try and find answers to these questions. So the neuroendocrine tumors, carcinoid syndrome. So this is actually a little high, 50%. It's probably closer to 20-30% of patients with NET. In terms of carcinoid syndrome, it usually occurs with liver involvement of the tumor, but not 100%. Okay. And why do patients develop carcinoid syndrome? Well, it's related to secretion of hormones or proteins. The one that we think about mostly is serotonin, but there's a slew of other ones that can be released and cause symptoms. For example, the flushing. We don't even think that's related to serotonin per se. We think it might be related to a hormone or a neuropeptide called substance P. So the hormones can be varied, but the classic one is serotonin, which does cause the carcinoid syndrome diarrhea. So we classically define carcinoid syndrome as flushing, most commonly diarrhea, followed by wheezing. But there's other symptoms, right, that don't fit that triad, those three. And those include sweating, abdominal swelling, abdominal cramping, skin itching, blood pressure lability, meaning going up and down, heart rate changes, headache. So there's a lot of different symptoms that don't fit into that, those three classically described symptoms. So triggers can be stress, exercise, alcohol, certain foods, and they can be debilitating, right? Diarrhea can occur at night and wake patients up. Patients can have 15, 20 bowel movements a day. They could be flushing to the point where it makes them have to sit down, and it's like an exhausting experience. Now we talk about this term called carcinoid crisis, and essentially what that is usually happens in the OR or even in the interventional radiology suite, where you manipulate one of these two tumors and there's a surge of hormones, and this results in actually low blood pressure. And patients, if they're not in the OR, obviously if your blood pressure gets low enough, can lead to fainting or passing out. So it's very important, if you do have a functional tumor, so you know that the tumor is making serotonin, for example, that your medical team prepare if there's a surgery planned for the cancer, whether it be or an interventional radiology procedure, that they have octreotide on standby, and we even give it prophylactically, meaning we give it before the procedure and during the procedure and sometime after. So make sure to talk to your medical team about that. So that's different than if a patient has these symptoms where they're severe in terms of the diarrhea and the flushing that cause the patient to go to the ER. So they get an exacerbation or a worsening of their carcinoid syndrome. That's not that's not classic carcinoid crisis, but it's kind of semantics, right? Because either way, octreotide is going to be the answer. So these are some terms, right, that we hear and can be very confusing when you're first introduced to this subject, carcinoid, which is an outdated term. However, we still use it for lung carcinoid, right? And hopefully the WHO catches up at some point and recognizes, like for gastrointestinal neuroendocrine gastrointestinal carcinoids, we now call neuroendocrine tumors, or the more aggressive form, neuroendocrine carcinoma. We talked about carcinoid syndrome, sandostatin, which is a medication that we had mentioned is essentially the brand name of octreotide. Lanreotide, which is the brand name of, is the generic for Somatuline. Localized. So what does that mean? Well, the disease is localized. It has not spread. Metastatic, the disease has spread outside of the origin where it started. Somatostatin, these are the receptors on the cell that we use to target with our octreotides and our lanreotides, in addition to our peptide receptor radionuclide therapy. So this is the receptor of focus. The brand name of PRRT is Lutathera. And Octreoscan is a historic term at this point, which has been replaced by something you might hear as a dotatate scan. We have Dotatox scan, which are essentially better versions of Octreoscan. They're more sensitive. The resolution's better. Chromogranin A, I spelt it wrong here, but in any case, we'll talk about that a little bit more. Tumor grade, right? One of the important questions that you should ask your medical team. What grade is my tumor? Carcinoid heart. We think this is due to serotonin doing damage to the valves in the heart, particularly the right side of the heart, right? So if you have high serotonin levels for long periods of time, this could do damage to the heart valves. And synonymous with octreotide or lanreotide, these are also called somatostatin analogs. Well, again, that somatostatin term is coming back into picture here. So here's fact or myth. Carcinoid tumors are synonymous with neuroendocrine tumors. True. But again, carcinoid is a misnomer, right? So although they're synonymous, it would be more proper to refer to a carcinoid tumor as a neuroendocrine tumor, aside from the lung. Neuroendocrine tumors are benign. We know that's false, right? So this was the original misnomer, and we still hear this. I have patients come in. I have a patient come in last week. What do you mean I have cancer? I was told that this was benign. And so even in the medical community, it's very common for there to be a misunderstanding of the disease. All patients with neuroendocrine tumors get carcinoid syndrome, and we know that's false, probably around 20 to 30%. Neuroendocrine tumors are the same as neuroendocrine carcinomas. That's false. Neuroendocrine tumors, by definition, are called well differentiated. So when Dr. Obendorfer looked under the microscope originally, he saw these little nests of cells that were very cohesive and they looked very neat. Those are well differentiated neuroendocrine tumors, or NETs. That's different than looking under the microscope and finding aggressive looking cells that are haphazard in their architecture, meaning they don't make nice nests. The cells are scattered. They look bizarre. These are aggressive and referred to as neuroendocrine carcinomas. By definition, those are grade 3. So chromogranin A is a reliable way to monitor neuroendocrine tumors. False. It doesn't mean that that you shouldn't have it drawn, right? It's still a number that you could potentially use as a marker for disease activity. However, understand that it's not specific, right? There is lots of reasons chromogranin A can be elevated. Patients on a proton pump inhibitor like Prilosec or Nexium, that will increase the chromogranin A. People with liver issues or kidney issues, that will increase the chromogranin A. Depending on the time of day, that'll change the chromogranin A. So I do not put much weight into a chromogranin A. You have to look at the company it keeps, right? What do the scans show? How are you doing as a patient, right? So I would stress to not get too fixated on the number, although it's okay to follow it, right? It's not wrong, but you just have to be cautious. Somatostatin analogs such as sandostatin, octreotide, and lanreotide are chemotherapy. That's false. So it's a form of hormone therapy. So some patients, when I would see them, would say, well, I'm on this chemotherapy, and I'd have to, and it might be semantics. But again, it's important to educate and to understand that, no, this is not chemo. This is actually hormone therapy, right? So I think that's a very important distinction. So here's some frequently asked questions that we have here for the last 5 minutes. Are neuroendocrine tumors curable? So this depends on the stage. So you want to know the stage of the tumor at the diagnosis, right? The earlier the stage of the tumor, stage 1, 2, 3, goes up to 4, the more curable it is, right? So surgery, I wouldn't argue this with surgeons. Surgery is the most definitive way to cure this disease, right? And so if there's an opportunity to remove the cancer and maybe surrounding lymph nodes, and even in the setting of stage 4 cancer, neuroendocrine tumor or neuroendocrine tumor, even in that setting, when it's spread to the liver, there is an opportunity still for surgery, but the curability of the disease definitely decreases. And so it should be very clear up front what the objective of the surgery is and what are the expectations, right? So it's very important to have that discussion because sometimes some miscommunication can occur. So even patients, and I alluded to this earlier, even patients with stage 4 disease can have an excellent prognosis and live many, 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 many years, right? So there's always hope, and we just have to try to take things a day at a time to the best of our ability. Is carcinoid tumor the same thing as neuroendocrine tumor? We talked about this a little bit. So the problem becomes when they're all used interchangeably. So neuroendocrine tumor, neuroendocrine carcinoma, carcinoid, all used interchangeably. And I see this probably once a week, where on the pathology report or in the outside notes, it says neuroendocrine carcinoma. That tells me right off the bat that that individual doesn't understand the nuances, right? No offense to them, and I understand because it's not taught very well probably in medical school or even fellowship. So it's really important not to use those interchangeably. They're not interchangeable. And we talked about carcinoid being an old, outdated term. Now, can you still say carcinoid? Sure, but just understand the meaning behind it, right? And so you want to try to speak the language to understand things fully. But I'll not correct someone if they say carcinoid usually, unless it's a fellow. So terminology is important. And as I mentioned, even the medical community doesn't quite understand a lot of the nuances, as I alluded to. So can diet affect my tumor? So here's the most common reported trigger foods: larger meals, high fat meals, alcohol, spicy foods, raw tomatoes, and foods with higher moderate amount of amines. That would be like aged cheeses or dark chocolate. But here's the thing: if those foods trigger carcinoid type symptoms, flushing, diarrhea, I would stay away from them. But if they don't, you don't have to stay away from them. So it's not a matter of avoiding these foods because they're going to do you harm. It's a matter of if these foods cause symptoms, you should steer clear. So here's some foods, as I mentioned, high in amines. We talked about alcohol, smoked meats, fermented foods, tofu, miso, sauerkraut. So these are some, moderate, and foods lower. Let's see, dark chocolate. Oh, dark chocolate's moderate. There we go. What is somatostatin? We talked about somatostatin a little bit. Receptors on the cell surface, but what is the actual hormone that you're receiving? So it's a naturally occurring hormone that's located in the stomach, small bowel, and pancreas, and its job is to inhibit the release of other hormones involved in digestion. Neuroendocrine cells and neuroendocrine tumors are rich with these receptors. So essentially, we exploit the fact that these receptors are present. We give the hormone to bind to then send inhibitory signals inside the cell, whether that be to stop dividing rapidly or whether it be to decrease the release of hormones. What is the role of somatostatin analogs? So as I mentioned, these bind to the cells and transmit inhibitory signals. What is a gallium-68 dotatate scan? So this was the one when I made this presentation that was generally available. There's now a copper-64 dotatate. There's a gallium-68 dotatalk. So there's a lot of these nuclear scans that are now available that are as good, at least as good as this gallium-68 dotatate, which we all got accustomed to earlier on. And you can see here in the liver, there's uptake of a neuroendocrine tumor with these receptors. So what receptor is the dotatate binding to? Well, it's the somatostatin receptors. And again, what receptor is the PRRT binding to? The somatostatin receptor. A little bit about lutetium-177 or Lutathera is approved in January 2018. Now, it actually, I put here grade 1 or 2 neuroendocrine tumors that starred in the gastrointestinal system or pancreas. The FDA actually gave a more blanket statement of approval. It was somatostatin positive gastroenteropancreatic neuroendocrine tumors. So they didn't even specify grade. I won't get into that too much, but just a mention of that. Is chemotherapy used? So chemotherapy is used in some situations. This combination, which we refer to as CAPTEM, particularly useful for pancreatic neuroendocrine tumors. Everolimus, not your traditional chemo, but still in that class. That is used in both small, bowel and pancreas. And sunitinib, for example, is used in mostly pancreatic neuroendocrine tumors. Hopefully, we can add to this list of effective therapies in the near future. And are neuroendocrine tumors inherited? So the majority are sporadic, but about 5 to 10% of pancreatic neuroendocrine tumors can be associated with something called multiple endocrine neoplasia, or MEN. But what we're learning is even the small bowel neuroendocrine tumors can have a familial pattern. And we're just kind of scraping the surface on this. So historically, I would tell patients, small bowel, there's probably no relationship to some DNA that you inherited from mom or dad. This is being challenged with some newer data. So stay tuned. In any case, have the discussion with your oncologist on whether or not genetic testing is appropriate. And I think that's on a case-by-case basis. So questions you should ask your doctor in the last minute here. What stage is my tumor? Where did my tumor start? What grade is my tumor? Do I need a dotatate scan or a PET scan essentially? Make sure the correct PET scan is done. Typically, for a higher grade cancer or a more aggressive cancer, you would want a glucose PET. For a lower grade cancer, you would want a dotatate or dotatoc. And should I see a NET specialist, I emphasize this earlier. And remember, when you hear hoofbeats, think zebras, of course. So, and there's strength in numbers, and I really appreciate the opportunity to speak with you all today. And I hope this was helpful.
No, it absolutely was. It absolutely was helpful. Thank you so much for sharing that with us. A nice little overview. And if you guys like that kind of information, you're looking for more information like that, please make sure you excuse me, make sure you go over to the NCAN YouTube page. We have years and years and years of presentations. And we have Dr. Starr's presentation from this past year's national conference on there as well. So please make sure that you check that out. Before we sign off here, I just got to remind everybody, please go to netcancerawareness.org, where you can find out about all of our upcoming events. We've got some upcoming live stream Q&As where you'll be able to see a short presentation from a doctor and also text in your questions. So stay tuned for a little bit more information on that. But also, if you want more news and stuff like that, also check excuse me, check out our social medias at Net Cancer Aware. We're on Instagram, we are on LinkedIn, we're on Facebook, and we're on Twitter. And all that information pops up from time to time. Thank you again, Dr. Starr, for joining us.
Pleasure.
And thank you, everybody, for checking out Nets Get Real, and we'll see you next time.
Sounds good. Happy New Year. Thanks for having me.